Great. Good evening, everybody. And hope you can see my screen and hear me okay. Any issues or any issues, let me know. Apparently, I have a little black line across the screen, so periodically, so just watch out for that. Hopefully, this will be a pretty quick overview. I wasn't sure how technical to get with this. I'm Jaspal Singh. I'm a pulmonary critical care physician in Charlotte, North Carolina. I am board certified in sleep medicine, and I do practice sleep medicine as well as I do a lot of lung cancer work actually in that space of cancer in the Cancer Institute in our pulmonary practice. So I'm going to talk to you a little bit about sleep and cancer, and just a little bit talk a little bit about the sleep disorders and the relationship between cancer-related conditions, and then talk about ways we can counsel each other and kind of help each other through this difficult journey involving sleep as well, and where that kind of all fits in. I do have a few disclosures. I don't know if we're getting kind of credits and stuff like that, but I do consult a little bit for a couple of companies, so hopefully nothing here is going to conflict with any of that stuff. And so main areas of the sleep cancer relationship. I think this is where we have to sort of step back a little bit. And what is this link between sleep and cancer? I think the questions come, is poor sleep or sleep disorder puts someone at increased risk of cancer, number one. Number two, does cancer itself or the treatments of it cause a sleep disorder or two? That's the other part of it. And then the other part of it is treating sleep disorders, how does that affect their cancer? And trying to understand those three domains is kind of what I'm going to kind of touch on tonight. So back when I trained, I used to call sleep, for those who are old enough, remember a guy named Rodney Dangerfield, a comedian, and he said we have this famous line, say, "I get no respect." And I have to say, as a sleep doc, we used to always say, you know what, we never got any respect, because the dietitians, the physical therapists, everybody else, like, you know, they'll mix these nasty juices that I still can't drink today, and they'll prefer that over getting enough sleep. They'll prefer that over getting the sleep evaluated. And so sleep was sort of like this, you know, the Rodney Dangerfields of wellness, essentially, as we called it. You know, no respect, not seen as important in our society, and almost seen as people wore a lack of sleep as a badge of courage. Like, you know, stay up all night. I worked all night on this. I didn't sleep well last night because I took care of X, Y, and Z, and so and so much. But I think our society finally is catching up to the idea that sleep is a critical part of our health. And I'm going to kind of walk through that a little bit. The hard part when it comes to cancer is how much of that is true association, correlation, or causation. Is poor sleep causing a health effect? Or are they related at all? Or are the associations we're seeing, are they due to random errors, some biases, or confounding? And I'll get to that a little bit, because what's hard about the sleep and cancer literature is a lot of that is sort of not well teased out. That there's sleep issues, there's health issues, and then it's not clear if you neutralize one, what do the effects really look like? And it's hard to know for sure. So how do you prove causation? Well, as scientists are always looking for the idea of how strong is the association, how consistent the associations are, how specific the associations are. Is there a sequence? One causes the other in a time-based fashion, or is what we call a biological gradient? The worse you sleep, does that cause an increase in signal? And then does it make sense? And then we look for coherence, we look for additional studies, a biological concordance, and some type of experiment. And we do that for everything. And so what we start to see, though, is that people tend to get very excited about causations and associations without a whole body of scientific literature to support that association. And we'll get to that in a little bit. So insufficient or poor quality sleep, what's it associated with when it comes to like a number of things, not just cancer, but immune system issues. For example, when I didn't realize this, when I was a resident, I wore that badge of honor where I didn't sleep well. I took on a lot of extra hours, and sure enough, my eczema would kick in. Eczema, which is a skin issue. I didn't know it was eczema. I thought it was just some fungal infection I picked up from the locker room or something like that. So I was like, you know, putting fungal creams on my skin, all this stuff, until I saw a dermatologist, said, this is just eczema. Took care of it, went away for a while. And it turns out every time I went into the night shift cycle of my training, the eczema would come up. And it was just one of those things that's very clear to me that immunologically there's a signal. And the same thing happens with patients with asthma, people with inflammatory bowel disorders. Things that are immunologic in nature actually tend to flare up when we don't sleep well. There's a risk factor. Weight management. Well, we know lots of studies now that suggest that, you know what, if you don't sleep well, not enough sleep, you have trouble with your weight management, you may have trouble with glucose metabolism, and now we're seeing things like cardiovascular, and we'll take a little bit more dive into the brain health, actually, a little bit. Cognition, and maybe even cognition disorders like dementia, work productivity, psychological well-being, and public safety. So I'm a pulmonary critical care sleep physician, and so I'm boarded in all three. My kids will tell you that when I'm super stressed out and I don't sleep, I'm like not a lot of fun to be around. So it definitely affects a lot of things. And then of course, public safety, the idea that sleep deprived truck drivers actually have just as much impairment as alcohol consumption people. And so when I have my teenage drivers, for example, we talk very frankly about the importance of, you know, insufficient sleep is just as much a risk factor as alcohol or other substances are. So you start thinking about this in those ways, and that's been shown by multiple studies. But cancer risk in sleep it's a little bit more interesting in terms of the biology of where is this signal coming from and how much of the linkage is real. Some animal studies suggest some of this, but this is a graph from a few years ago. It's since gotten much more complicated. There's all kinds of biological mechanisms out there. I'm not going to sort of overwhelm you all, but this is a nice article that's out of Sleep Medicine Reviews, and that shows like sort of like what are some mechanisms? Well, what are some of these terms? If you're not a scientist, this may seem like just Latin for you. If you are a scientist or a biologist, or even then, it's still not clear how things move around. What one thing leads to the next thing. And it just shows how complex our bodies are. But a lot of sleep is generated from parts of the brainstem. We'll talk about that a little bit. And that also involves a lot of direct connection with our hormonal system. Then you add the inflammatory system of our bodies, the various systems that are there to protect us when we have injury or protect us from cancer and other things like that. And so it becomes this sort of interesting assortment of problems that can intersect in a lot of very complex ways biologically, resulting in sleep disorders or sleep disorders resulting in worsening cancer risks. And so the relationships are just very complicated. Here's one depiction of it. But the idea that poor sleep and cancer might be linked has some biological potential basis. What do I mean by that? Well, when you and I wake up from sleep, it turns out that the hypothalamus, which is deep in our brain here, and very close to our hormonal system actually, and regulates our hormonal systems, is very active at that point. The wakefulness to sleep. Cancer itself is also very inflammatory. Inflammatory reactions even occur even during chemotherapy, when we actually try to shut all that down. Some of it's still ongoing. And immunotherapies, that are what we call targeted or biologic therapies, may even work better with sleep optimization. And we can talk about that, debate that a little bit. There are certain chemicals like melatonin. Does it have a biological effect? And there are certain things like light. Does night light promote tumor development? There's interesting ideas out there that are being floated, and animal studies are going on right now. And we'll talk a little bit more about shift workers. So some of the breast cancer work back in a couple of decades ago was looked at. So I'm a shift worker at times in the hospital, and I work with a lot of nurses who are shift workers. And they always ask me, like, you know, I heard shift workers are associated with risk of breast cancer and maybe some other cancers. And it's not clear, but there are some interesting data out there that suggests, you know, if you're a shift worker and work a lot of nights, whether you're a nurse or a police officer or, you know, hotel clerk, that there might be a higher incidence of things like breast cancer and maybe even colon cancer now. And it's becoming very interesting. Sleep duration. So people always ask me, like, you know, how long should I sleep? I sleep 7 hours, 6 hours, 8 hours, 9 hours, and nobody really knows. It's probably 6.5 is probably sufficient. It's probably the minimum for most people. About 8 hours is probably pretty good, 8 to 9 hours, maybe 10. When we start getting above 9 to 10 hours actually of sleep at night, it may be associated with poor health, in fact, worse health. And longer sleep times can be associated with things like lung cancer, and in a women's health study with liver cancers. Not to say everyone who sleeps longer is going to have liver cancer. It's a very small, very small percentage. But the associations are interesting. Well, why is that? And people are trying to answer some of these questions. And so some people went and tried to figure out, you know, in cancer patients, what is their sleep like even? Let's describe it. So for those who had cancer, or, you know, others who have cancer survivors, oftentimes they have other issues besides cancer issues and besides sleep that they're worried about, right? So pain, they may have breathing disorders, for example. Like I take care of a patient with lung cancer. Some of them don't breathe very well. And that's what their predominant concern is, right? They're not thinking about sleep. I just need to be able to breathe better. Hormonal dysregulation. For example, they may be like my ovarian cancer or breast cancer patients, maybe on hormonal therapies, or that's part of their treatment, for example. And they just may be dysregulated from a lot of different things. And so therefore, they're associating this with hormonal issues. Medical treatments, some of them can clearly affect your sleep, especially like all the neuropathies or some of the other pain issues involved. That can be important. Alcohol, a lot of patients with cancer do partake in alcohol more than they probably tell me. I don't really push it either, but that's an issue. Or other substances. Psychological factors. Many people are just worried about the effects of cancer on their life. It causes a lot of stress, anxiety, other things of that nature. And so obviously sleep is not surprisingly not high on their priority list. And then psychosocial factors, thinking of like, my loved ones. What are some of the things that I didn't get to do in my life yet I want to make sure I have time for? Or how am I going to get this next job? How am I going to support my family? How is so-and-so going to survive without me? All those things are huge. And so it's not surprising that self-perception of sleep problems is low. In fact, in most studies, actually, so I thought this was interesting. When they looked at sleep in other studies, actually, people reported maybe 20% prevalence of problems. But if you actually put people objectively to quantify on a scale how bad their sleep is, a lot of them actually, almost half of them had a significant problem, what would actually be rated as poorly sleeping. What was really interesting is that many survivors, even years out, sleep poorly. And we see that a lot. And I can tell you all about that later. So why such a low self-perception of sleep problems? I think, like I said, competing issues. Your cancer diagnosis, the treatments, the mortality of it all. It's scary, it's stressful. And I think the other problem societal is that we've normalized poor sleep. And I'd almost say we've almost glorified sleeping less in our society, and even though non-cancer people. So when non-cancer folks talk to cancer folks, they're like, I just sleep well that night. That's not either. And end up sort of minimizing all those issues. And so something to think about. And then daytime sleepiness is also normalized. For many people, it's not normal to be it's not normal to be tired in the daytime for a lot of things, but to be sleepy in the daytime while you're doing normal activities is not normal. But we sometimes will say, oh, so-and-so has cancer. That's normal for them. But we don't actually inquire as to why they're so sleepy because we assume it has to do with the treatment. And I think many of us can relate to that. Pain, other discomfort like neuropathies can overshadow the sleep issues. And the other thing I would say is the medical system, including myself, we don't do a great job prioritizing this, especially in cancer work. We sort of say, oh, you're seeing your oncologist, you may see your primary care doctor, you may see one specialist or two specialists, maybe a surgeon or a radiation therapist. Now you got 3 appointments. Now you're going to add a sleep person on top of that or somebody else on top of that. And we just do a crappy job. I shouldn't have said that on a recorded line, but we do a terrible job in terms of coordination and being really patient-centered here. So, and many clinicians themselves are not very comfortable with these issues. They're just not trained to think about these issues. And so I thought this was interesting because basically in this study, actually, as I'm kind of mentioning earlier, actually, they found that of these 107 patients, 68% had a prevalence of significant sleep disorders. Now, this population was some hospitalized patients as well, but it's a lot higher than was previously reported. Some studies as low as 20-30% of patients had problems. In this study, over 2/3 had problems with sleep, if you objectively look for it. So what I'm saying is it's there. This is like the tip of the iceberg. What we're seeing when I see someone, it's the tip of the iceberg. There's probably a whole bunch of people I'm not seeing right now with sleep issues that just don't make it through. And then, like, what issues do they have? Well, insomnia, the insomnia severity index, actually, almost half of them had some degree of insomnia, and 15% had moderate to severe insomnia in this study. This is just a very small study of 100 some patients, but I can attest to this, probably higher than that in my population of lung cancer that I take care of. I just haven't really studied it. And then what are the key risk factors? Well, if you have a lot of pain issues, if you have depressive symptoms, Do you have any anxiety? Do you have any social distress, like change of jobs, especially high stress, or worries about your family, workplace, and financial situation? It's about a third of our patients, they really have a lot of trouble with sleep. Their sleep is generally going to be poorer. Now, patients who don't have pain issues, feel pretty good otherwise, don't have a lot of anxiety, don't have a lot of job stress, or financially secure, those people who have good support systems, they tend to report in general better sleep. That's not a surprise, right? You start thinking about, okay, who are the ones that are going to potentially be at risk here? Well, you start thinking that people have, single income families, for example, a lot of stress issues, a lot of poor sleep issues. And then, like I said, there's a lot of different mechanisms that are out there, but they all kind of start to come into play, not just with the aspects of cancer related, but also other issues that sort of get involved: weight issues, nutrition issues, diabetes, especially patients on steroids, for example, for their cancer or cancer related effects. They have a lot of diabetes prevalence, and the sleep issues become embedded into all of that. Now I'm gonna sort of shift gears a little bit here. I love how these scientists actually in this study in 2016 actually highlighted, this is in Science actually, sort of looking at the hypothalamus. I mentioned this organelle earlier, actually, this part of the brain, this part of the center of the brain actually. And it's really interesting how the day-light cycles, or what's called a circadian rhythm, affects the transcription of genes. In fact, those genes result in a tremendous amount of impact on what we call brain homeostasis, or actually the rest of our body's ability to manage its own health issues. And sleep is a part of it. So when your sleep is off, it's possible other parts of your body are off. And if sleep is off also, it's possible that's affecting other parts of your body. So it's a kind of it's a double-edged sword. And what's really interesting is that the same scientists also found that, also described how basically certain sleep disorders are associated with more significant disorders, like what we call REM behavior disorders, or mouse models of Alzheimer's disease, Parkinson's disease, Huntington's disease. And these are just neurological diseases, but you can imagine, you think about cancer survivors, how many of them are out there now? How many of them say that they have memory problems? If we assess them, if we checked with them, how many of them would say that, you know what, I'm not as clear thinking as I used to be? I would argue some of that could maybe have been modulated if we knew a little bit more about their sleep habits and be able to sort of really develop this sort of combination of things that we pay attention to. One of them being sleep. Of course, people would argue that I don't have data, but I don't want to wait for all the data to come through, because I think the data is compelling enough and it's logical enough. Now, obstructive sleep apnea itself, which is a problem with sleep apnea. So my pulmonologist, my oncologist all make fun of me. They've made fun of me for years. And a lot of us get this. They get told, well, you know what? This person's having a sleep study for sleep apnea. Saying, what are you thinking? This person already has cancer. They need to get through this cancer treatment. They need to go through that part. Don't bother with sleep study. It turns out they had sleep apnea before they even got diagnosed, potentially a lot of times. And it turns out that actually treating their sleep apnea with a simple CPAP actually helped them think more clearly, be more alert, be able to process more information. And it turns out actually obstructive sleep apnea may be linked to cognitive decline long-term. So not treating it, to me, not diagnosing, especially a severe case, and not treating it, to me, is akin to me telling somebody that, you know what, I'm going to ignore your other health issues completely, your diabetes management, your other stuff, until I control your cancer. And that's just not smart medicine. That's just not a good way to approach our patients, because that's certainly saying that, you know what, you only have one health issue to worry about. You don't have others. You don't treat your hypertension. You don't treat your diabetes. You've got to treat all this stuff in order to get them the best chance of a functional survival afterwards. Other immune issues, we talked about eczema, allergic rhinitis, intermittent asthma. All of them, and there's a ton of data now coming out that all of them have some relationship to sleep disturbances. Now, cancer in OSA, there's a nice systematic review that was done a few years ago, actually, and started showing some degree of where obstructive sleep apnea, especially if it's severe, those patients tend to have a higher incidence of cancer, and vice versa. The more severe your obstructive sleep apnea was, the more likely you were to have cancer or something related to that. But again, not all these studies are really designed to look at sleep apnea and cancer per se. Well, hopefully some more studies are coming out. The other thing is that obstructive sleep apnea isn't an all or none phenomenon. It's that some people have a very mild case. Some people have a very severe case where their oxygen levels drop substantially. Which are the ones that potentially have the most most at risk here. We're still trying to understand that part. Where is that threshold that we really get to really have, that we have to literally dive in and take care of somebody more aggressively. And again, it's hard to know with these small studies what to do. And then we don't really know a lot about specific cancer sites. The study I showed you earlier had a bunch of different cancer types, different sites, and there's so many confounding variables, like how they're sleeping, where they're sleeping, who they're sleeping with. Obviously, as you know, cancer affects intimacy, the home situation a lot. And so depending on certain types of cancer especially, and it can affect how people sleep at night. And so we don't really capture a lot of those very complex dynamics, which oftentimes we keep very private. And then the other part of this really interesting, cancer-related fatigue. Now, this is not sleepiness per se, but the fatigue itself could also be a problem itself, because that may be biologically mediated. In fact, those same immune cells that are affecting the sleep issues may be affecting the other parts of fatigue aspects. And so we're trying to understand all this stuff right now. So finally, the Cancer Network is actually working on basically at least paying attention to this. And so now we have basically some nice validated severity scores that are out there. And if you haven't seen one before, if you have patients or family members that want to be aware of this thing, just go to that Cancer Network website, which is right here, and start thinking through some of these assessments and start thinking through how to make your sleep better. A lot of times people ask me what are other types of metrics, and so you might have heard of sleep diaries or the ISI we just talked about, but there are other sleepiness scores too. We do in our office the Epworth scale for sleep apnea, for example, or in anesthesia, we do what's called a stop bang tool. Some primary care doctors also do that as well. But the idea is that basically you're looking for certain aspects of how sleepy is someone really. Well, after a good night's sleep, they should be a lot more relaxed. They should be a lot more alert. This is some of that data that I mentioned earlier about the night shift workers. Basically, this is from the 2015 that was published, but they basically interviewed 712 women who had invasive breast cancer before treatment, and they found that the night shift workers had a higher risk. Well, this is important to me because I work with a lot of ICU nurses at night or nighttime hospital staff. And so it's very important. Particularly interesting was that if you nap in the daytime and you work the nighttime, you had a lower risk. So you can modulate some of these factors. That if you actually get a nap before you go in, so when I go in before the night, my family knows I'm taking a nap before I go in, because I can't just suck it up for all night. It's just too risky for me. And the other thing is sort of young patients with severe obstructive sleep apnea. In this single center study, actually, they did an overnight sleep study, actually. If they had an age below 45, a very severe case of sleep apnea was associated with a slightly increased risk of cancer than the general population. I thought it was kind of interesting. I also thought this is really interesting, actually, that actually if you have obstructive sleep apnea, it turns out if you have a cancer called melanoma, cutaneous melanoma, that actually you're more likely to have a more severe case of it, which I thought was particularly interesting. And so the idea that a dose response, that if you don't, the less you sleep, the more likely you are to get cancer of this type, and the more aggressive it might be. So I thought that was a very interesting biological plausibility aspect for it. Of course, we got to remember that we live in 2020s, and there are a lot of naysayers out there who are very public and don't believe science. And so they sort of will tell you, well, you know what, check yourself a little bit, saying, and colleagues, the sleep industry needs a reality check here, that we have to kind of get away from all this. Sleep is not an issue. This is just big business. It's just big pharma trying to sell us medications. Maybe. But essentially, what I would say is that sleep, to me at least, is almost a no-brainer in terms of how we approach it. I make sure all my patients know the quick sleep tips to make sure that they do a good job keeping a schedule, setting a bedtime, make sure that they're paying attention to how awake and sleepy they really are. Establish a relaxing bedtime routine, limit exposure to bright lights, which is really hard, especially in our teenagers or younger people with cell phones these days. It's impossible to turn the cell phones off at night. I cannot get them to do that. Not eat large meals before bedtime, exercise regularly, maintain a healthy diet, and then caffeine. We still live in a very caffeinated society, so trying to limit the caffeine intake. And of course, alcohol. In our cancer patients, alcohol, unfortunate to say, is probably more consumed than we realize for people to deal with a lot of the issues affecting them. And then, of course, reduce your fluid intake before bedtime, which is a huge issue for my cancer patients who have been told by either chemotherapy, the medical oncology community, to stay hydrated to protect the kidneys. They have a hard time staying a little dehydrated at night, so they don't have to get up and pee all the time. Those are just some common things. People ask me about medications. Again, the hard part about cancer patients with medications, you'll see a lot of doctors reluctant to prescribe medications in their cancer patients because of it, a lot of these drugs are affected are metabolized by the liver. And if they have liver metastases or liver problems, or maybe at risk of liver issues with chemotherapy and such, people may be reluctant. People are reluctant about addiction and dependence issues. And then, of course, things like if some of these medications can unmask some mood disorders, some like depression and anxiety, make things worse. Also, for a lot of insomnia, the best treatment options are actually what's called cognitive behavioral therapy for insomnia, or called CBTI. And so CBTI is an intensive treatment with a psychologist. Well, if you have chemotherapy or sitting in a chemo chair every couple of weeks or radiation therapies regularly, are you really going to go to another psychologist while you're going through all the other stuff multiple times a week? It's going to be hard. It's going to be almost unrealistic. The fact that they also charge more, a lot of money oftentimes, the good programs charge a lot, it's hard to really justify some of these things. So it's really hard. So that kind of ends my talk, because I want to make sure I kept it short. That there might be a relationship between cancer risk and poor and insufficient sleep. The patients with cancer often sleep poorly. That cancer and its therapies may be causing sleep disorders. And that sleeping better may affect overall health and well-being, but might it also affect the cure rate from cancer? We don't know yet. But so much to be learned in this space. And I just want to thank you all for coming tonight. And I have a lot of colleagues, mentors, all of you that have helpful. And thanks Jen for inviting me. This is my email and my link. I'm on LinkedIn and Twitter, is probably the easiest way to get a hold of me if you need to. And I just want to open the floor for questions.